Why? So,
Right, you should be good to start.
Oh, good.
so basically, I'd like to welcome you back today, and some of you were present at the meeting yesterday, the closed meeting. It was 3 hours of nonstop discussion of ongoing concepts and some new ones. And I think that the meeting went very well. Today, the focus will be on open trials, not only SWOG, but also the NCTN. But we will discuss some of the concepts that are close to activation, or at least close to going to the exec committee. What I'd like to do next, can we have the next slide, please? So I'd like to introduce you a few of the people are involved in our operations and thank them. Obviously, on behalf of my Vice Chair, Dr. Ang, who you know very well. We also would like to thank Dr. Ryan, who's been really very helpful for the committee and giving us advice and how to go forward with things. Next slide, please. And then we have other people who are involved in the committee. Dr. Washington, pathologist, Dr. Lenz, who you know runs the translational research along with Dr. Liu and Dr. Catenacci. And we have Dr. Berman from surgical oncology, Dr. Ahmed, surgical oncology, who also happens to chair the surgical committee. Dr. Shields, my colleague who works with me in the same institution. He is our imaging expert. And Dr. Kachnik, who you know very well, a radiation oncologist, and she's been involved with SWOG for such a long time. Next slide. Dr. Zell, who leads the cancer prevention efforts in our committee. Dr. Barzi, who is also involved in cancer control. Dr. Buscher-Schacher, who is community liaison. And then we have Dr. Salim, who also is a community liaison and very active in his area of research in GI cancers. Dr. Horowitz is another doctor who helps us from the community. Dr. Shen, and Dr. O'Rourke, who also is an expert on symptom management and also patient-reported outcomes. And then Dr. Deniv, who is also a surgical oncologist from the community. Next. Next slide, please. Okay, Dr. Patel, who is our liaison for new drug development, phase 1 in particular. Dr. Flavio Rocha, he's a very active surgical oncologist, again from the community. Dr. Suarez, who is our point person for digital engagement. And then we have the invaluable support from Dr. Rogers, who is the pharmaceutical science liaison, and then also Dr. Reed, who also functions in the same space. Next, please. Next slide. We really get tremendous and invaluable support from our colleagues who help us develop the concepts, help us to get them through the executive committee, then to the steering committee. Dr. Guthrie, who you know very well, she's our statistician who's helped by Ms. Dong. Again, in the statistics. And then we have Christy, who all of you know very well. She's our protocol coordinator, and she does a lot of the work that goes behind the scenes to help us really navigate this whole thing throughout the year. Next slide, please. We have also the support of Ms. Annis and also Mr. Gorung, Ms. Magner, Ms. Scarlock, and also Brian Zeller, who is involved in the data collection. Next slide, please. And finally, I'd like to thank Courtney Wells. She really was extremely helpful in trying to put this whole thing together, not only for the GI committee, but for other committees. Doing the virtual program is different than the in-person, and she really made sure that all the slides are put together, the decks prepared, and also all the logistics that go along with this virtual meeting. We're hoping that this is the last time that we do it this way, and I'm hopeful that the fall meeting will be in person. And I'm really looking forward to that, to help networking and all that, which have really been minimal with Zoom meetings. Thank you. Next slide, please. I'd like now to introduce our committee patient advocates, Ms. Cotella and also Ms. Siegel. Maybe Flora or Carol, you can say a few words to tell us more about what you do and what are the things that you feel excited about in this committee and how you see the future. Okay.
Okay, maybe not. She was having difficulty. So I'll just say a few words about what's going on in advocacy. And if Flo comes in, please speak up. Big things have been accomplished in the past year within the Patient Advocacy Committee. The Team Science Module 6, titled Improving Diversity and Representativeness of Clinical Trial Participants, will roll out in May and June. In addition, the integration of the community advocates into the clinical trial development and representing various patient populations instead of disease groups will begin shortly. Rick Bangs will present a more complete update at the next plenary meeting. And if you need further help, please get in touch with one of us. We believe that the year 2021 should have a high priority in addressing diversity and equity in our accrual goals. The SWOG commitment to plain language is a great beginning, and the updated website has been reworked in language for all of us to understand. Now, descriptions of clinical trials speak to patients in words that are understandable, respectful, and reassuring. Hopefully, all patient-facing information, including the informed consent, will follow suit. Another breakthrough is the finding to just ask. A study was published in the Journal of National Cancer Institute, which found that at least half of patients offered participation in a clinical trial did participate. The findings did not differ between treatment and cancer control trials. Importantly, Black, Hispanic, Asian patients participated in trials at the rates at least as high as white patients. The next big breakthrough is the passing of the Clinical Treatment Act in the last session of Congress, which mandates by federal law that Medicaid insurance coverage for routine care costs when patients participate in clinical trials, and it'll be implemented this January 2022. It will open doors to clinical trials for low income and ethnically diverse patients, which, as we know, will result in more meaningful research results. Another significant step is that the FDA has developed guidelines aiming at broadening eligibility in clinical trials. Restrictive eligibility criteria results in the difference between a clinical trial and real-world treatment results. And researchers are encouraged to define eligibility criteria that allows the broadest participation possible. Currently in Congress, there's the Telehealth Modernization Act, which will continue Medicare coverage after the current pandemic crisis and will remove the restricted requirements that a patient live in a rural area and only access telehealth at a doctor's office or clinic. Telehealth is a big boon for clinical trial participants and reduces inequities in care. It enhances communication between provider and patient, increases treatment compliance, reduces ER visits and hospital admissions, and enables palliative and supportive care. So let's work together to make it pass. We can now build on these findings. They provide the basis for actionable goals in 2021, leading to the aspirational goal of developing a healthcare system that is equitable and available for all. If there are any questions, please feel free to contact either Flo or myself. We thank you for taking the time to let us speak about what advocacy is doing at SWOG. Thank you.
Thank you, Carol. And again, on behalf of the committee, we very much like to thank you for all the effort you're putting through these initiatives, and this was very helpful for everyone to know, and in fact, very useful information. Thank you very much
Yep.
again.
Thank you.
As we move forward today, a couple of housekeeping things. One is if you're not speaking, just mute. And the second one is we really encourage active participation. So please use the chat function, and we will be looking at the questions and addressing them as we go along today. The next item is to go over three what we call feature trials that are important for us, for the community to really be aware of, to encourage participation, and also for you to let us know if you have any concerns about eligibility or anything like that, so we can fix things early on rather than wait for having problems and then coming back to it. So we'll start with Dr. Sun, who's going to briefly discuss SWOG 1820. Dr. Sun is the...
Yes. Hi. Thank you, Dr. Phillip, Dr. Ang, for the opportunity. I'm going to give a really quick update. I think hopefully next slide. On 1820, this is an NCORP trial, preliminary efficacy randomized trial of altering intake, managing symptoms, AIMS-RC, to manage bowel dysfunction in rectal cancer survivors. In the yellow box here, just a quick overview of the eligibility criteria. We're enrolling rectal cancer survivors. Our target sample size is 94, 47 per arm. These are real, true post-treatment survivors, 6 to 24 months post-treatment completion. We are enrolling ostomy or anastomosis participants, and English speaking for this trial, 18 years and older. And we have been activated since December 9, 2019, and I'm very happy to share that we are, as of now, 53% accrued, 49 out of 94 randomized. So appreciate everyone's participation on this trial, and please feel free to reach out to me if you have any questions. Thank you so much for the time.
Dr. Sam, thank you. Thank you very much for telling us about the updating on the study. I don't see any questions, so maybe we can go to the next one. But if we have any comment about 1820, we'll come back to you. Dr. Chung, SWOG 2001.
Yes, thank you, Philip. Next slide, please. So S2001 is a randomized phase 2 trial of olaparib plus pembrolizumab versus olaparib alone as maintenance therapy in metastatic pancreatic cancer patients with germline BRCA1 and BRCA2 mutations. This was actually developed in collaboration with Alliance, and Michael Pishvine is my study co-chair. Next slide. So in 2019, olaparib was approved based upon the POLO trial, which showed an improvement in median progression-free survival from 3.8 months up to 7.4 months in patients receiving maintenance therapy with germline BRCA1 and BRCA2 mutations. Now, since then, there's been a lot of interest in terms of how to improve that, because that was actually an incremental improvement. And there's been much preclinical work done regarding the combination of checkpoint inhibitors with PARP inhibitors. So what is the background with this? Well, there have been preclinical studies that have demonstrated that PARP inhibitors modulate the immune microenvironment by increasing genomic instability, PD-L1 expression, as well as activating the STING pathway. And we know that patients with germline mutations already have a higher innate genomic instability, thus underscoring the rationale regarding the combination of checkpoint inhibitors with PARP inhibitors for this population. We also wanted to test this in a genetically engineered mouse model, and looking at this BRCA2 genetically engineered mouse model, which recapitulates the normal pathogenesis of pancreatic cancer, as you can see on the right-hand side, with the development of normal pancreatic ductal tissue to PANN1 through PANN3 to invasive cancer. We looked at the combination of olaparib in combination with the PD-L1 antibody, and what we showed was that the combination of the PD-L1 monoclonal antibody with the olaparib had superior survival compared to single agent alone. Next slide. So the primary objectives of the study is to evaluate the progression-free survival of the combination of olaparib plus pembrolizumab compared to olaparib alone as maintenance therapy in germline BRCA1 and BRCA2 mutated pancreatic cancer. And we're again following the POLO trial looking at progression-free survival. The secondary objectives are to evaluate the safety and tolerability, overall survival, overall response rate, as well as to bank tissue and blood samples for correlative studies. Next slide. These are some key eligibility criteria. Number one, of course, diagnosis of pancreatic adenocarcinoma. But number two, BRCA mutations, basically in the NCCN guidelines in 2019, germline testing is now recommended for all patients with pancreatic cancer. So whenever you actually see a pancreatic cancer patient, you should go ahead and order one of the CLIA certified tests like Myriad Genetics, Invitae. There are many, many different CLIA certified germline testing companies, but that should be actually initiated upon diagnosis. So patients must have a positive and or deleterious, which is pathogenic or likely pathogenic variant of BRCA1 or BRCA2. They must receive at least 16 weeks, but no more than 24 weeks of first-line platinum-based chemotherapy, and also have good performance status of 0 to 1. Exclusion criteria, if patients are starting their first-line therapy and you're seeing signs that they're having progression such as rising CA19-9 or the tumor size is increasing, these patients are not eligible. If they've received prior adjuvant therapy, they are eligible if the progression occurs greater than 6 months after the completion of the adjuvant therapy. Any previous treatment with PARP inhibitors is excluded from the clinical trial. Next slide. So this is the treatment schema. Again, this is a maintenance clinical trial, so patients need to receive first-line platinum-based chemotherapy. I think that, one of the things that we need to remember is that, again, when you're seeing a newly diagnosed pancreatic cancer patient and you send them for germline testing, that result is going to probably come back in like, 2 to 4 weeks. So you have to be, cognizant of the fact that for this particular clinical trial, the patients must receive platinum-based chemotherapy, which means that they should receive either FOLFIRINOX, FOLFOX, or gemcitabine and cisplatin chemotherapy. So if you're suspecting that the patient, may be potentially a candidate for this clinical trial down the road, you'd want to go ahead and start the patient with the platinum-based chemotherapy. If you start gemcitabine and nab-paclitaxel chemotherapy, later on find out that they're BRCA mutated, they would not actually be eligible for this clinical trial. So just, keep that in the back of your mind when you're seeing your pancreatic cancer patients. After 4 months and no more than 6 months of chemotherapy, they would then enroll in the clinical trial and get randomized to either olaparib 300 milligrams twice per day, which is the FDA recommended dose, or olaparib plus pembrolizumab 200 milligrams every 3 weeks. The patients will be stratified according to first-line chemotherapy, performance status, as well as disease status after first-line treatment. And we are targeting a hazard ratio of 0.6, so we're looking for an improvement of median progression-free survival from 7 months to 11.7 months. And this will require a sample size of 88 patients, which we hope to accrue over the next 3 years. So this study was opened in December of 2020. We're very excited about this study opening up, and we're actively looking for patients. I recently just had a patient that was diagnosed with BRCA mutated pancreatic cancer. So we're waiting for that, 4-month time frame to be able to get them on trial. I did want to give you a few pearls of wisdom for this trial in terms of what to also think about, because again, this is a maintenance trial, so you won't be actually accruing them onto the trial until 4 months of treatment. This study does bank tissue, and many patients are diagnosed with a fine needle aspirate. So when you're seeing that a newly diagnosed pancreatic cancer patient that has a fine needle aspirate as their diagnosis for going on the treatment, you want to consider going ahead and getting a core needle biopsy of a metastatic site, for instance, a liver lesion or any other accessible site. This is for 2 reasons. Number one, NCCN guidelines actually recommend somatic mutation testing for all patients with advanced pancreatic cancer, and this has helped to identify potential actionable mutations down the road. But number 2, having a core biopsy of a metastatic site will allow you to have enough tissue to be banked for this clinical trial. the next thing is, of course, just remember that this requires platinum-based chemotherapy. So whenever you're actually going to be starting a patient on chemotherapy, think about FOLFIRINOX, FOLFOX, or gemcitabine and cisplatin chemotherapy. So I'd be happy to take any questions. I'm really excited to have the study open and looking forward to your participation.
Thank you very much, Vincent. Just not to confuse people, this is germline, not somatic mutation.
Exactly. Yes.
Yeah, I mean the fact that you brought up um, uh, the core biopsy of the liver, it's not for the BRCA. I mean, you can check the BRCA, but this is germline to get
Yes.
it to.
Thank you.
Okay. Thank you very much. I don't see any questions, so we can move to SWOG 2104. Dr. Suarez?
Yes, thank you very much, Dr. Philip. If you can have the next slide. So first of all, I want to thank you for the opportunity to present the study. The study is not active yet. Hopefully, we'll have this study ready for activation by the fall. These are all the important people that help us to move this trial along. Special thanks to the Dr. Ahmad and Dr. Strasberg, as well as Dr. Gutter and Mei Dong, in addition to Kay Washington, Dr. Philip. This started, Dr. Philip was talking about networking. This started about 3 years ago on one of the meetings when Dr. Ahmad and myself, introduced by Dr. Philip, started to brainstorm about this concept. So I'll be forever grateful for the opportunity. And then it's super exciting because this is going to be the first randomized trial to look in the role of adjuvant cytotoxic treatment in patients with pancreatic neuroendocrine tumors. Next slide, please. Next slide. Just a way of introduction for those who haven't seen me talk about this trial before, neuroendocrine tumors tends to be more indolent disease. Hopefully surgery is the curative approach for patients that have localized disease. And we know that patients with pancreatic neuroendocrine tumors, they tend to recur a little bit sooner than other tumors in the GI tract. And here is a curve that was published in 2018 that showed that, the time to recurrence for pancreatic neuroendocrine tumors in terms of all comers neuroendocrine tumors, pancreatic neuroendocrine tumors can be is about 26.5% in 3 years. We know, take into account several different retrospective studies that have the median time for recurrence will be between 24 to 36 months. And there are several prognostic factors that suggest that the tumors in patients that are most likely to recur, including the size of the tumor. The bigger the tumor, the higher the risk of recurrence. For example, tumors that have a size more than 4 centimeters. Positive lymph nodes, a higher grade and a higher Ki-67. And patients that had oligometastatic disease but had been resected will likely recur sooner as well. Next slide. This is again a table with some of the studies that have been done. I'm not going to go into detail to this table to be respectful of time, but in general, just to highlight that if they were to recur, many of these patients will actually recur between 2 to 3 years. Next slide. When I was initially discussing this study and went to the task force and our own group, one of the criticisms that they impose is that, well, perhaps even if you detect the recurrence or avoid that, it's not going to necessarily impact the overall survival of these patients. And I'm just going to back a little bit and show you that if they were to recur, they tend to recur in the liver. And here you can see that the median recurrence-free survival of these patients with pancreatic neuroendocrine tumors was 20.2 months. Next slide, please. Here's the point that I was started to make, that thanks to the work from the U.S. neuroendocrine tumor study group, which accounts for 8 U.S. institutions, the group was able to show that the patients that had recurrence indeed will have their survival affected. So that's a point of argument that indeed is important to try to develop adjuvant strategies. Next slide. Next slide. And you can click 2 more times probably. So to this date, there is no randomized trial that have been done to assess that. We have a publication that was presented at ESMO as an abstract about the real world experience in China between 2018 and 2008 and 2018. And patients with grade 2 pancreatic neuroendocrine tumors received somatostatin analogs versus observation for a period of time. And even though this was not a control study, it does suggest, if you see in the bottom, that patients that receive octreotide had longer disease-free survival. Next slide, please. So if we want to think about our adjuvant strategy, what are the options that we have, especially taking into account some of the strategies that we use in the metastatic setting? Well, we have somatostatin analogs, we have everolimus, and we have sunitinib. They are all cytotoxic agents that probably are not the best if you want to really eliminate disease. Then we have immunotherapy that we have used in other disease, but there's really lack of data about efficacy in the well-differentiated neuroendocrine tumors. What about PRT? Well, it's a rather costly treatment. There are issues with potentially long-term toxicity, and we don't know exactly if the lutetium-177 will actually target microscopic metastasis. But we have cytotoxic chemotherapy, thanks to the a study that was conducted within the Claparib group mechanisms of CTAP. We were able to show, Dr. Kunz presented a study that showed that capecitabine and temozolomide versus temozolomide by itself indeed improve progression-free survival of patients and survival of patients with pancreatic neuroendocrine tumors in the metastatic setting. Next slide. So based on that, we developed 2104, which is a phase 2 randomized trial of adjuvant capecitabine and temozolomide versus observation in patients with high-risk pancreatic neuroendocrine tumors. The design of the trial has evolved a little bit thanks to the feedback of my SWOG colleagues, the NET Task Force, and CTAP, and the GI Steering Committee. And right now, patients that have high-risk features for recurrence, which I'll touch in the next slide, will be randomized in a 2-to-1 fashion to receive CAP10 for 4 months versus observation. And these patients will be stratified according to the grade of the tumor and the stage. The primary endpoint of this trial is 3 years detection of 3 years recurrence-free survival. Here's how the dosing of the drug will be. Tumors will be assessed with imaging every 6 months for the first 3 years, and then annually in the subsequently 3 years. The way that we design it, we are planning to enroll a total of 154 participants to have 141 eligible patients. And we hope that we're going to decrease the recurrence-free survival of these patients. Next slide. In terms of what are the patients that are at high risk for recurrence? This is our initial design. This is still evolving a little bit thanks to the feedback from CTAP, but we hope to enroll patients that have resection of the tumors within 90 days. Patients will be eligible if they have a grade 2 tumor that is well differentiated with a tumor that is equal or more than 4 centimeters or has 1 positive lymph node or more. Patients that have well-differentiated grade 3 tumor and a Ki-67 less than 55% will also be eligible for this study. Additionally, patients that had oligometastatic disease up to 5 liver mets and have a well-differentiated tumor that's a grade 2 or grade 3 will be eligible for this study as well, assuming that all the visible disease has been resected. We will exclude patients with poorly differentiated tumors. Patients with germline mutations that are associated with pancreatic neuroendocrine tumors will be allowed, and we will not allow for any neoadjuvant treatment. But somatostatin analogs used for the control of symptoms will be allowed prior to the surgery. Next slide. I'd like to thank everybody that has helped to move this study forward. This is going to be an important trial to answer a very important question, whether or not there's a role for adjuvant treatment in pancreatic neuroendocrine tumors. You know, the patient advocates have been great to give us input, Mark Lewis as well, and currently we're working with the Digital Engagement Committee and with SWOG leadership to create more awareness of this trial. Thank you.
Thank you, Louisa. And again, this is the first trial ever to be done in this setting, so this should be a great study. Um, for the future trials, we have a couple of questions. There's one comment from Dr. Lee Ellis about us engaging the basic scientists, specifically Dr. Ed Liu, and we will do that. Thank you, Lee. And then a couple of questions about tumor mutation burden and PDL1. This is referring to 2001, by the way, the Vincent Chang trial. And two questions that are similar about TMB and PDL1, whether it's affected by treatment with platinum compounds and hence response to immunotherapy. The second question is similar to that. So will you be looking at TMB and PDL1 at all in the tumor specimens?
Yes, so I mean, we are collecting tumor tissue, so we do want to go back and retrospectively look at it. We're not going to be looking at it prospectively. We do know from other tumor types that the PDL1 expression does increase after chemotherapy treatment, so we expect to see that as being high.
Yeah, I mean, both are soft biomarkers. I mean, they're not really major ones compared to MSI high. Thank you very much. For the sake of time, now we'll be going straight to gastroesophageal. And again, I have to remind the presenters, we don't have a lot of time today like yesterday, so we really want to be very cognizant of that. So gastroesophageal, I'm not sure who's presenting. Is it Saima or Zev? Next slide. Saima or Zev? We can't hear you. Saima or Zev?
Philip, I don't think they're on. Why don't we go on to the next one and I will find them.
Yes, okay. So let's go to hepatobiliary. Thank you, Kathy. Can we move? Can we proceed to hepatobiliary, please?
Sorry, it's Zev. My
Zev,
audio is
okay.
working now.
Okay, all right.
I apologize for that.
No problem, Zev. Okay.
And so I'm happy to talk, and Simon's here too, but we'll go through quickly some changes in the field. Next slide. So we're going to go over the active NCTN studies first. And then we'll talk about some concepts and development as well that we've been working on through SWOG over the last few months. Next slide. So we have to recognize that this has been a big year, and for gastroesophageal cancer, the landscape has completely changed just in the last year, and that has meant new FDA approvals, and more importantly for our purposes, new study designs that are going to be required to replace what were old study designs because of this standard of care changing so very much. Next slide. So perhaps the biggest change was based on this large study, CheckMate 649, that randomized patients to chemotherapy or chemotherapy plus nivolumab up front in newly diagnosed patients with metastatic gastroesophageal cancer. Next slide. And the study here met its primary endpoints, both for the CPS 5 category and in fact for the all-comers category as well, albeit with a far less impressive efficacy advantage. Next slide. Practically speaking, what this means is that as of last week, the FDA has approved nivolumab with chemotherapy, and it's gave it a very blanket approval, such that for now, at least until the dust settles here, the new standard of care in upfront gastroesophageal adenocarcinoma is chemotherapy with nivolumab, and that does change, as mentioned, some of our existing concepts and requiring us to modify them. Next slide. The Keynote 590 similarly looked at esophageal cancer and combined pembrolizumab with chemotherapy. Next slide. And here too it met its endpoint. Next slide. Which led to the approval of pembrolizumab with chemotherapy. So now what we've had in the last just month, 2 months, is new FDA approvals upfront of pembrolizumab and nivolumab in newly diagnosed metastatic gastroesophageal cancers. Next slide. And also in the adjuvant setting, where the CheckMate 577 study was randomizing patients post-operatively after esophagectomy to nivolumab versus placebo. Next slide. And here met its endpoint quite emphatically and just published last week in the New England Journal of Medicine. And this has changed the adjuvant therapy. Next slide. That doesn't even begin to address the biomarker question. And we are now in a situation where we are fortunate that we have several biomarkers which look promising. There's second-generation drugs going after HER2, moving beyond just trastuzumab. There's Claudin, which is Claudin 18 to be specific, which is a biomarker of interest in gastric cancer. We're waiting for a big result there in the field. And FGFR2b also, which is also has randomized phase 2 data now showing a benefit of an antibody with chemotherapy. Next slide. So fundamentally, we try to look at this pie chart and we try to think about which are the key markers for patients with newly diagnosed disease. We are getting to a point where we can look at patients prospectively with these biomarkers. HER2, MSI high, and PD-L1, we start to think, certainly based on the data we know so far, those are the 3 actionable biomarkers right now in frontline disease. The investigational ones, which include Claudin, FGFR2b, and even FGFR amplification we have positive randomized phase 2 data waiting for randomized phase 3 trials to develop. And what this means in practice is that our job designing new studies has to modify accordingly. Next slide. So Saima, are you on now? Well, I'll just go through the existing trials if Saima's not on. And the open study for which is being run by ECOG, for which the SWOG champion is Dr. Caitlin Kelly, is randomizing patients to either carbotaxol with concurrent radiation or carbotaxol nivolumab with concurrent radiation, followed by an esophagectomy, followed by nivolumab or nivolumab ipilimumab. And this is a timely trial based on the fact that the nivolumab approval is now the case. So this really follows the standard of care. Fortuitously, the study design is actually quite interesting because it not only looks at nivolumab upfront with radiation and chemotherapy, but also looks at adding second immunotherapy drug adjuvantly. So a really important study, I think, and a timely one. Next slide. The other study that's also being run by ECOG takes patients with oligometastatic disease, so asking a different question about the role of chemotherapy versus consolidation radiation in those patients with isolated or oligometastatic disease. Next slide. And finally, the NRG study, which looks at 2 different forms of radiation, proton beam radiation versus IMRT, for patients receiving carbotaxol and radiation up front. It was activated 2 years ago and is planning to enroll 300 patients. Next slide. So we spent a lot of time yesterday talking about a Nivo-Cabo trial that Anwar Saeed is leading, which we're moving through. That's an example of a trial that was already planned to be going on in refractory gastric cancer, but now is in light of these approvals, is moving to a maintenance concept. Next slide. So we'll be looking at a maintenance question, which is an altogether different question, not yet asked in the field and not yet addressed. And this is a way in which, a trial that was planning to go forward prior has now required modification. But here we have a study design where patients will be randomized once they hit maintenance to either a VEGF inhibitor, cabozantinib plus PD-1 nivolumab or ramucirumab nivolumab, or continuation of chemotherapy nivolumab, which is now the de facto standard of care for these patients. Next slide. And the statistics are listed here, but needless to say, we're shooting for an impressive PFS advantage in either of the two arms over a continuation of chemotherapy and nivolumab alone. And if so, will lead ultimately to a phase 3 study. And we're hoping to be active while we're working on the final protocol modification over these next 6 months. Next slide. Joe Chow from City of Hope has been working diligently on a perioperative study. We are trying to incorporate as many of those actionable biomarkers as we addressed earlier. Some of this is a little challenging in light of these companies' ongoing phase 3 efforts, but we have some degree of acceptance across cooperative groups to focus on a perioperative study, which will include HER2, adding a second agent to chemotherapy trastuzumab, PD-L1, which we already know has now some data with nivolumab, but looking at different perioperative setting, and MSI-high looking at even no chemotherapy option in upfront prior to surgery. And this trial is also in its evolution being modified in the next few weeks. Next slide. And our endpoints here will be primarily based on pathological response rate as a perioperative study, which we hope to ultimately signal some degree of efficacy pathologically, which will inform all the other clinical endpoints. Next slide. So what are we doing moving forward? We're starting to incorporate ctDNA, and we're working with some of the other cooperative groups, so we're not duplicating efforts, but trying to incorporate ctDNA testing in the approach of neoadjuvant therapy. We are starting to look at second-line therapy because first-line therapy now is pretty crowded and the standards have changed, as I mentioned. Second-line therapy, the standards have not changed to the same extent. And so we are trying to think and brainstorm about a second-line concept. And of course, refractory therapy, which remains an unmet need, and an increasing group of patients with gastroesophageal cancer who are receiving refractory treatment. Next slide. And that's it for the gastroesophageal section at this time.
Well, thank you very much, Zev. And I just want to see whether any of your colleagues, either Saima or Daniel, have anything to add or have any comments. If not, and I can't see any questions in the chat box, so we can then proceed with hepatobiliary cancers. Again, thank you very much, Zev, Saima, and Daniel. Rashna or Anthony or Said? Rashna, Anthony, Syed. Okay.
I think Sai's having some, I see he's on, but there's no microphone. I don't know if he's having connectivity issues.
Shall we go to pancreatic because we don't have much time to play with? Let's go to pancreatic then. Next slide. Just move, please. Next. 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 Next slide. Next slide, please. Okay, here we go. Okay. I think Andy is going to present.
Actually, Gabby was going to start, and then
Okay.
we were going to hand off. I think
Okay.
she is on.
Yeah.
Okay.
Hi, everybody. We're going to be probably much briefer with pancreas. I wish so many things were happening in pancreas as they are in gastroesophageal. Next slide. A few updates from ASCO GI. In borderline resectable pancreatic cancer, neoadjuvant FOLFIRINOX was tested side by side to neoadjuvant FOLFIRINOX followed by stereotactic body frame radiation, and both arms then received surgery. Following surgery, patients received adjuvant FOLFOX. This study really wanted to determine whether SBRT has a role in borderline resectable pancreas cancer. Next slide. The results have shown that actually FOLFIRINOX followed by SBRT did not meet the pre-specified guideline of improving R0 resection, and in fact that arm of the study was discontinued early, close to accrual early. On the left panels, top and bottom, you see the overall survival and the event-free survival in the FOLFIRINOX alone neoadjuvant therapy. The overall survival was actually almost 30 months and the event-free survival of about 15 months with FOLFIRINOX. Contrary to that, the FOLFIRINOX followed by SBRT had actually numerically lower numbers, both for overall survival at approximately 17 months and event-free survival of only 10 months. Small patient numbers make us very, very really uncomfortable telling why this SBRT arm actually ended up being inferior to the chemotherapy, because all we've done was substituting a cycle of FOLFIRINOX 2 weeks with SBRT. Nevertheless, there were more patients in the SBRT arm which developed metastatic disease between chemotherapy and radiation, and between radiation and surgery. We are planning to form actually a working group across NCTN to really study more the question of, is there really a role for radiation therapy in borderline resectable pancreas cancer, and trying to shed more light and to see where should the radiation therapy be studied more or less in this context. Next slide. In terms of other updates, the POLO study, which was previously presented at ASCO 2019 and published in the Journal of Medicine, we know that in germline BRCA mutated pancreatic cancer patients who have response or stable disease after at least 4 to 6 months of platinum chemotherapy, maintenance olaparib versus placebo confers an improvement in progression-free survival of approximately 50%. Next slide. At ASCO GI, Golan and co-authors presented the final overall survival analysis of the POLO study. And in the blue line, we have the olaparib, and in red is a placebo arm, showing that despite a numerical improvement at 3 years in terms of overall survival, overall there was no statistical difference between the survival arms, in the treatment arms, 19 months in each arm. Therefore, again, olaparib does not improve survival in germline mutated pancreas cancer patients, despite the fact that some people seem to derive benefit. Again, the question is why pancreatic cancer patients BRCA mutated have inferior outcomes, so to speak, to PARP inhibitors comparing with the breast and ovarian cancer counterparts. And again, the research into the DNA repair damage response pathway is furthermore extremely important, because clearly some people benefit and some people don't. And dissecting furthermore the pathways of resistance and potentially other markers of success is very important in this disease. Next slide. Some other updates, CD40 agonist, which basically activates the antigen-presenting cells and potentially converts the inflammatory macrophages to immune-active macrophages in pancreatic cancer, has been published by Mark O'Hara and co-authors in Lancet Oncology recently. This was actually a 4-arm clinical trial testing gemcitabine with nab-paclitaxel with CD40 agonist by Apexigen with or without nivolumab. What we see here is that there had been very encouraging responses. And again, a small study, difficult to say what the final efficacy is, but this is an agent that could potentially play a bigger role in pancreas cancer. Next slide. This is another immunomodulatory agent which targets CD73, the adenosine immunosuppressive pathway. Again, a very small study showing responses of about 40% of a PD-1 inhibitor in combination with CD73 small molecule inhibitor with gemabraxine in pancreas cancer. Again, another pathway that is being tested in pancreatic cancer. Next. And I think this is a last, update from ASCO GI. This is a CXCR4 inhibitor that we spoke about in other, in the close meeting. And we are interested to study this pathway more in the neoadjuvant platform study of Davendras and Venupilariseri and Syed. So this is motixafortide, the BL8040 of BioLine-RX with PD-1 inhibition. A trial in progress. This is a combination of gemabraxine in metastatic treatment-naive pancreas cancer. Again, this pathway is of high interest. Next. And
okay, I'm going to take over from here and just talk about the NCTN studies which are open. So going from early to later stage disease, this is a study being run by Alliance. Steve Berman is our SWOG champion. Christina Ferroni is the overall PI. So this is a study, an important study to ask the question regarding the use of perioperative chemotherapy. In this case, all chemotherapy is FOLFIRINOX versus the traditional adjuvant chemotherapy for patients with resectable pancreatic cancer. As you can see from the schema, patients will receive a total of either 8 cycles of upfront chemotherapy followed by surgery and an additional 4 cycles versus the traditional 12 cycles postoperatively. This is, as you might imagine, this is a phase 3 study. It's a large study with a projected accrual goal of 344. It has been fairly slow to accrue so far. And so we really want to encourage all sites to consider opening and accruing to the study. It's very important both to answer this question, which is one that's been in the field for a long time, as well as to allow us to perform other studies in resectable and borderline resectable disease. And I'll talk about one later that we have proposed at SWOG. Next slide. This is ECOG 2192, a study that is being co-led by our own Anoop Kasi and Kim Rees-Binder from Penn. This is a study also for patients with resectable pancreas cancer, but it's asking the question in patients who have received neoadjuvant or adjuvant therapy with a platinum-based regimen and who have pathogenic mutations in BRCA1, BRCA2, or PALB2, does maintenance olaparib improve overall survival? And so, this is a similar question to, that being asked in some of the other studies, namely SWOG 2001, which is studying this population. We're interested in this population with DNA damage repair deficiency. So this is taking the POLO study and really moving it into the resectable patient group. And so this study is just about to open. Not sure that it is open quite yet, but it should be opening imminently. And we obviously hope that folks will support it. Again, it's a restricted patient population, who have mutations in the BRCA or PALB2 genes. Next. This is ECOG 2186, being led by Efrat Dotan from Fox Chase. Our SWOG champion is David Zen. This is a very important study as well, because it's the first of its kind really to study the chemotherapy in the elderly population. It is studying 2 different regimens, a modified gemcitabine nab-paclitaxel regimen, comparing with Naliri. And so this is for treatment-naive patients with metastatic disease. They undergo geriatric assessment initially, and then are randomized, assuming they are in what is considered the vulnerable group with mild to moderate abnormalities based on the geriatric assessment. And so this is an important study. It's going to accrue 184 patients. It is actually accruing pretty well, which is encouraging, but we certainly encourage people to consider accruing to this study, given that so many pancreas cancer patients fall into this group and we don't have a lot of data. And this will be one of the first studies to shed light on this question. Next slide. I won't spend much time. You already heard Vincent present on SWOG 2001, but just to doubly emphasize how important we think this study is. Obviously, it's a very small patient population, so we need participation from a wide group of investigators. And so just another plug to support this study that is now open. Next slide. So now I'm just going to talk about some of our trials in SWOG that are in late stages of development to get you excited about them. This is a study being led by Greg Botta from UCSD. We're very excited about this study. It's a randomized phase 2 comparing gemcitabine and nab-paclitaxel versus gemcitabine nab-paclitaxel plus a novel agent called SEND1 in the treatment of first-line metastatic disease. SEND1 is a peptide which there is a lot of preclinical data and now some clinical data on from a phase 1 study in Australia. The peptide seems to increase drug penetration into the tumor microenvironment to decrease the incidence of metastases via mechanisms I don't really have time to go into. But suffice to say, in the phase 1 study in Australia, which was obviously a single arm in patients with treatment-naive metastatic disease, added to gemcitabine nab-paclitaxel, the disease control rate was 93%, and the objective response rate was over 50%. Obviously, numbers that compare extremely favorably to any data that's out there on gem nab-paclitaxel. And so,
good, Mr. How are you?
So I think someone's not muted. And so we are very excited to send this to pursue this trial, and it's received very favorable evaluations at the level of the Pancreas Task Force, and so we anticipate hopefully this will go to the SWOG exec imminently and hopefully get opened towards the end of this calendar year if we're lucky. Next slide, which I think is the last slide. And so this is a concept being led by Devendra Sohal and Syed Ahmad, really to follow up on SWOG 1505, which you recall compared gem nab-paclitaxel and FOLFIRINOX in resectable patients as neoadjuvant regimens. We now want to build on the findings from that study, and this proposal basically proposes a neoadjuvant platform trial where we can add novel agents to a chemotherapy backbone in the neoadjuvant setting. We have two potential arms that are being proposed. One, a metabolic agent, CPI 613, compound made by Raphael, and then CXCR4 inhibition as a strategy, which you heard about from Gabby as a promising strategy. We also hope to do some very robust correlative science, working with several investigators on understanding whether we can develop assays to predict chemosensitivity using either RNA-seq-based methods or using organoids and organoid-based pharmacotyping. So we hope to kind of use this neoadjuvant platform as a wonderful platform to do science in our patients and to really move the field forward. And so this is another study which has been worked on for quite a long time, and we anticipate moving to SWOG exec and to the GI steering committee for approval in the near future. We will stop there in the interest of time, and we're both glad to answer any questions.
Thank you, Gabby, and thank you, Andy. We have one question, but let me just pass a message to Bill. Bill, can you go back to the hepatobiliary while we're dealing with this question? So there's a question from Gary. He asks about the perioperative versus adjuvant chemo trial, since so many centers have moved to neoadjuvant chemo as their standard. Has anyone run into resistance to putting patients on this study?
Well, I can answer from our institutional experience. I think that when this study was designed, I think we all realized that there's going to be some bias, in terms of the patients that get enrolled. And honestly, we have the trial open. We have accrued 2 patients to the study, but I don't approach all patients, with this study, because I do feel, myself, that for patients, for instance, who have a very high CA19-9, or have medical comorbidities to where I think they're at increased risk for surgery, I don't really feel, very good about offering them a randomization. And so we've tended to, focus on patients who are good performance status patients, who have, early, clearly early resectable tumors, so smaller tumors, no equivocal findings of lymph nodes, et cetera, not super high CA19-9. And I think ultimately that's probably going to be the patient population that makes up most of this study. Obviously that doesn't answer the question for these other groups, but I think that there should be equipoise in at least subgroups of patients with resectable disease, because I do think that we don't have definitive data on what the right strategy is. So, I think that's the best way I can answer it. The patients that I've chose to talk to about it have been receptive. Many patients still want to have surgery first. And I think, in the right circumstances, this is a very valid question that's important to answer.
Thank you very much, Andy. Again, thank you, Andy and Gabby. Now we go back to hepatobiliary and Dr. El-Khoueiry.
Hello, I'm happy to present on the behalf of my co-chairs, Dr. Rashna Ashraf and Sai Ahmad. Next slide, please. First, I will give you an overview of the lay of the land in biliary cancers currently, then speak about the SWOG and the other cooperative group studies. Next slide. So gemcitabine and cisplatin continues to be the standard of care first-line treatment for advanced biliary cancers based on the ABC-02 trial that showed superior overall survival with the combination compared to gemcitabine alone. Next slide. So the OS was 11.7 months with the combo versus 8.3 with gemcitabine. Next slide. In second line, next slide. Based on the ABC-06 study, which compared active symptom control after progression on one line of therapy, which is GemCis, to active symptom control plus modified FOLFOX as listed here, with a primary endpoint of overall survival. Next slide. This study showed a modest improvement in overall survival. Next slide, please. A modest improvement in overall survival with FOLFOX compared to active symptom control, as you see here, 6.2 months versus 5.3, with a hazard ratio of 0.69. Next slide. What's more important is that biliary cancer now is being broken down into several molecular subtypes. There is an extensive list of molecular alterations that occur in intrahepatic versus extrahepatic biliary cancers versus gallbladder carcinoma at differing frequencies. Next slide, please. So FGFR alterations are more frequent in intrahepatic, especially FGFR2 fusions. Next. IDH mutations are also more frequent in intrahepatic cholangio. Go ahead and hit this multiple times, please, to get through this slide. BRAF HER2 alterations tend to be more common in extrahepatic and gallbladder cancers, and so do MET alterations. Next. Based on this, there are emerging targeted therapies that have shown efficacy in this disease. First, ivosidenib, which targets IDH1 mutations, was evaluated in a phase 3 trial. Can you please go to the previous slide? In a phase 3 trial with a primary endpoint of PFS. This was a mixture of second and third line patients who had progressed on gemcitabine-based therapy. And you can see here an improvement in PFS with a hazard ratio of 0.37, even though the absolute numbers are modest, and certainly longer and higher disease control rate with treatment compared to placebo. When looking at overall survival, next slide, this was a secondary endpoint, and the study did allow crossover. So when looking at the overall survival, there was a hazard ratio of 0.79 in favor of ivosidenib, but it did not reach statistical significance due to the significant crossover. When adjusting for crossover, this was a pre-specified analysis, the hazard ratio was 0.49, with the overall survival being 10.3 months with ivosidenib and 5.1 months in the placebo arm when adjusting for crossover. Next slide. Several FGFR inhibitors are being evaluated in advanced cholangiocarcinoma, with pemigatinib having already garnered accelerated approval after one or more prior lines of therapy based on a response rate of 36% and durable responses, and a promising median PFS and median OS, as you see in this table. There is consistent data across the other agents, with infigratinib having the largest data set with over 100 patients. An NDA has been filed for this agent as well, and it's currently being evaluated in first-line therapy, and so is pemigatinib. And other agents that are in evaluation or have smaller data sets are listed here as well. Next slide. Lastly, for patients with BRAF mutations, the combination of dabrafenib and trametinib has also shown very promising efficacy based on data presented at ASCO 2019 and already published in Lancet Oncology. Next slide. So coming back to our SWOG efforts, this is the first-line SWOG studies, SWOG 1815, that took advanced cholangiocarcinoma and gallbladder patients previously untreated and randomized them in a 2-to-1 fashion to the triplet of gemcitabine, cisplatin, nab-paclitaxel versus gemcitabine, cisplatin. This is based on very promising phase 2 data that Dr. Schroff had published with the triplet combination. The study was initially designed to accrue 268 patients with an ambitious hazard ratio of 0.63. Next slide. These are the phase 2 results showing a median PFS of 12 months, which is similar to the median OS that was previously reported with gemcitabine cisplatin, and a median OS of 19 months. A very promising response rate as well. Next slide. It's important to acknowledge the efforts across SWOG and the efforts of Dr. Schroff, particularly in driving this forward and getting it open in really record time and beating the NCI target activation date for this study. Next slide. Next, please. Again. And you can see here that this study had very respectable monthly accrual rates, surpassing 20 patients and surpassing expectations, reflecting an excellent intergroup collaboration. The temporary dip that you see after March or February 2020 was because the study was being amended. Next slide. To allow for increased accrual after discussions with the NCI based on the robust accrual. Next slide. Here you see the breakdown that all the cooperative group participated with SWOG leading the pack here and leading the study. Next slide. So with the updated design, please hit this one more time. We were able to discuss with the NCI, adjust the hazard ratio to 0.7 and increase the total accrual to 441 patients. And we were able to achieve that and close the study to accrual on February 15th, 2021. Again, this is a monumental achievement. This is the first national randomized phase 3 study in advanced biliary cancers to be done in the United States. And it showed the feasibility of performing such studies in a rare tumor like this. Next slide. Also to be acknowledged is the monumental effort in collecting biospecimens, including blogs, slides, and blood samples in a serial fashion on this study, and we will be working on the correlative. We are working on the correlative biomarker for this. Next slide. At the national front, ECOG is leading a study in gallbladder cancer. This is focused on incidental gallbladder carcinoma, where it's been shown that the outcomes are better with repeat operation for these patients who are noted to have incidental gallbladder cancer on cholecystectomy. But not only this, it was shown in several studies that having residual disease was associated with poor outcome, and having higher T stage was associated with poorer outcome. Based on this, next slide, there was an interest in exploring neoadjuvant therapy in incidental gallbladder cancer to reduce the incidence of residual disease, improve resectability, improve patient selection for re-resection by allowing the biology to manifest itself, and hopefully improving survival. Next slide. So this is the design of this current study. Patients with incidental gallbladder cancers can be enrolled after baseline imaging showing no distant disease and pathology review. If they're eligible, they're randomized to surgery up front versus gemcitabine plus cisplatin, which is the experimental arm. After 4 cycles of therapy, 3 months, patients then can undergo staging laparoscopy and resection in the experimental arm. After resection, both arms receive gemcitabine and cisplatin for 6 months in the case of surgery arm and for 3 months in the case of the experimental arm, because patients had already had a pre-op therapy. The primary endpoint is overall survival. Next slide. And here are the specific aims of the study, and it's a critically important trial and really requires collaboration across all the cooperative groups. So if you have not considered the study, please do so. Next slide. Our areas of focus for development in biliary cancers are to explore targeted therapy in the perioperative setting. We have an emerging concept, but it's quite early. It's not mature for discussion in this forum yet. We would like to build on the data that's emerging in first line with the triplet combination, but we're awaiting the final results of that study as well, and are interested in concepts in second line for all-comer patients who do not have specific molecular alterations. Next slide. For HCC, next slide, please. Atezolizumab and bevacizumab has become the new standard of care for Child-Pugh-A patients who have not been previously exposed to systemic therapy, based on this study showing a median OS of 19 months with this combo versus 13 months with sorafenib. Very nice early separation of the arms, which is sustained over the duration of the follow-up. Next slide. Now, besides this becoming the new standard, there are multiple other combinations under evaluation for first-line HCC. These include IO plus TKI, such as Pembro-Lenva, and IO-IO combinations like Durva-Tremi or Nivo-Ipi. We're also awaiting the COSMIC-312 results with Cabo and atezolizumab combinations. In second line, even though there are multiple agents approved, these were all evaluated post-sorafenib, and they include regorafenib, cabozantinib, ramucirumab, as well as single-agent Nivo and single-agent Pembro. However, there is no standard post-atezo-bev, and this is an area in need of further development. Next slide. As far as cooperative group studies, the NRG-GI003 study is a phase 3 trial comparing protons versus photons for HCC that's limited to the liver. A vascular invasion is allowed with some limitations. And the current accrual is 53 out of 167. This slowed down during COVID, but it's picking back up again. And again, it's an important study looking at the role and the best type of radiation in this disease. Next slide. These are the eligibility criteria. I already mentioned them. So next slide. RTOG 1112 was a very important study looking at the addition of SBRT to sorafenib in first-line HCC with patients with BCLC-B or C disease. You can see the eligibility here in the first box. There were multiple stratification based on known prognostic factors. This study accrued slowly, and it was the victim of multiple limitations, including the evolving field. It did close to accrual with a total of 193 patients, so short of the planned total accrual. And we're awaiting the events that are accumulating. There are potential follow-up studies being planned with SBRT and atezo-bev, and hopefully we can continue to explore the role of SBRT in this disease, especially in patients with vascular invasion. Next slide. On the SWOG fronts, we have two concepts that are in development. One looking at neoadjuvant nivo-ipi in patients with resectable HCC led by Dr. Kasib, and a study looking at durva-tremi in patients with advanced HCC and Child-Pugh-B cirrhosis led by Dr. Arora. Next slide. Next slide, please. Can you hit it again? So this study has evolved. The current concept is that we would take patients with resectable HCC who had no prior therapy, well-compensated Child-Pugh-A disease, and we would have a run-in that will be focused on establishing safety and pathologic response rate. There was a single-arm study done at MD Anderson by Dr. Kasib that showed promising results, so we would like to validate this in a national setting with 30 patients. If we achieve certain benchmarks, meaning the probability of failure to reach resection does not exceed 20%, and the observed pathologic response rate is 15% or greater, we will then move to the randomized setting. Please hit the slide again. To a randomized phase 2 design where patients will be randomized to surgical resection versus neoadjuvant nivo-ipi. Next. Next. And here the primary endpoint would be median recurrence-free survival with multiple secondary endpoints and definitely exploratory endpoints related to biomarkers. Next slide. We are going to aim for a hazard ratio of 1.5, which will require an accrual of 88 patients per arm. Next slide. This is the schema for treatment. Patients will get nivo every 2 weeks, ipi at 1 milligram per kilogram Q6 weeks, and the surgery will be between weeks 12 and 14, and then they'll be on surveillance with follow-up. Next slide. Moving gears to the Child-Pugh-B cirrhosis study with durva-tremi led by Dr. Arora. Next slide. So Child-Pugh-B cirrhosis represents an area of unmet need. Some of these patients have a preserved performance status, and they're not clinically decompensated and requiring multiple paracentesis or hepatic encephalopathy. And there is limited data for sorafenib and for nivolumab in this setting. The sorafenib data is from a phase 2 study that included 28% of Child-Pugh-B patients. And the nivo data is from CheckMate 040, which had a specific cohort for patients with Child-Pugh-B 7 or 8, where the median OS was 7 months, and the overall response rate was 12% with single-agent nivolumab. This is now listed on the NCCN guidelines as an option for patients with Child-Pugh-B cirrhosis. Next slide. With the evolving field for combinations in this disease, we selected the combination of durva-tremi for evaluation given its favorable tolerability profile. Based on study 22, the regimen was given with one loading dose of tremelimumab at 300 milligrams once and continuation of durvalumab. With this approach, the tolerability and the incidence of grade 3 and 4 events was certainly manageable, and there was a promising response rate of 24%, a median OS of 18.7 months, mostly post-sorafenib in this study. But these patients were all Child-Pugh-A. Next slide. So the current design is for a single-arm phase 2 study. These patients would have had no prior systemic therapy, Child-Pugh-B 7 or 8, and preserved performance status. We would have a run-in of 10 patients to establish safety, and then we would move to the expansion phase with an additional 49 patients. The primary endpoint will be overall response rate, secondary endpoints of safety, OS, PFS, and quality of life. Next slide. I think this may end my presentation at this point. Next. Oh, these are the inclusion criteria, which mirror the Child-Pugh-B cohort for nivolumab from CheckMate 040. So we have an accurate historical comparison. Next slide. Just for the record, these flowers were planted by me.
Oh, wow. Thank you. This is a great presentation. Thank you very much, Anthony, as always. And thank you for your co-chairs also, Dr. Sharaf and Dr. Ahmed. I don't see any questions directly to the hepatobiliary, and what's happening is some of the questions are coming a bit later. So like there's a question from Vincent about the drug that Dr. Lowy mentioned, SEND1. Is it the same as Halozyme PEG drug? The answer is no, completely different. Okay, if there are no other questions, then we can move on
can I ask
to
a question? I'm so
colon.
sorry. Anthony, Himalaya
Yeah.
study, when will we have results? Because I recall we had actually a second line proposal from Gentry King with durvalumab second line after atezo-bev, and I thought that was actually a brilliant endeavor. But of course, it really matters what happens with Himalaya.
Thank you. You know, Himalaya is the first, just in case somebody doesn't know, Himalaya is the first line trial comparing durva-tremi to durva alone and to sorafenib. And this study has completed accrual, expected to read out in the second half of this year. Not sure if we may see something at ASCO or shortly thereafter. And it's based on this that AstraZeneca has prioritized first-line development and is very supportive of the Child-Pugh-B concept with this combination, but they were not as enthusiastic about the second-line evaluation of this combination. Gabby.
Yeah, I think that's fair.
Thank you.
Okay, so we have, thank you. Thank you again, Anthony. We have 30 minutes left and we have 3 disease sites. Next, we have colon, Doctors Messerschmidt and Dr. Gold.
Yes, thank you. We don't have any flowers, Philip, but we'll do our best. I'm very impressed, Anthony, with your gardening skills. So I'll just start out with a couple of background slides. Next slide. This is our agenda. I just have a couple slides on ctDNA, and then we'll go through active SWOG and NCTN studies, and I'll be turning it over to Dr. Gold. Next slide. So ctDNA, you'll notice across multiple studies, especially in the colorectal group, circulating tumor DNA has really taken the forefront in terms of a predictive and prognostic marker. And I would point you to this really nice white paper that was written by Dr. Tassari, who trained here at Colorado, by the way, and Scott Kopetz from MD Anderson. Next slide. This is a figure from that white paper, just showing some of the technical aspects of measuring circulating tumor DNA. It's helpful as you're reading the literature and looking at studies to sort of delve into the details about exactly what assays were used, whether they were a personalized assay to the tumor or more sort of off the shelf, looking generally for mutations. Next slide. And of course, there's been multiple publications on this topic. One of the more recent ones was a couple months ago from the Danish group, Dr. Henriksen at the GI Symposium. I'd refer you to Dr. Tena Henriksen, the presentation. It's online for the GI Symposium. But they followed about 260 colorectal cancer patients. Approximately 63% received adjuvant chemotherapy in one form or another. Most of the patients, as you can see there, were stage 3. And this was a tumor-informed ctDNA assay. So in other words, the tumor was tested, and then a customized circulating tumor DNA assay was designed for that patient. But here you see the very powerful effect size of the ctDNA negative patients in green and the ctDNA positive patients in blue. And the big difference in terms of the curves. And so the question is, how can we use these tools in our trials and in clinical practice? And you'll see that many of our studies are addressing this issue. Next slide. And I'll turn it over to Phil.
Thank you, Wells.
Thank you,
Good morning,
Wells.
everyone. We're next going to review the active SWOG studies. Next slide, please. Thank you. First up is 1613. This is Dr. Raghav's study. He is the PI. This is open throughout the intergroup. This is a randomized phase 2 study of trastuzumab and pertuzumab versus cetuximab and irinotecan in patients with metastatic colon cancer harboring HER2 amplification. This trial is given in the second or third line. No prior cetuximab or PMAB is allowed. And patients are randomly assigned between those two arms of trastuzumab, pertuzumab versus cetuximab and irinotecan, and there is a permissible crossover for arm 2 over to the experimental arm. The primary endpoint is progression-free survival. Next slide, please. And currently, this trial is open throughout all the NCORPs. There have been 215 screened patients, 55 patients been HER2 amplified, and a total of 45 patients have been randomized. So the study is about 1/3 done. The study has had a number of challenges. The central lab has, I believe, moved twice. Between that and the pandemic, it's been a bit of a challenge. However, just a few months ago, the precision enrollment process became active, which is a collaboration between the study and Foundation Medicine, so that docs who are submitting the test to Foundation should be notified of the patient's potential candidacy for this trial. Really highlights the importance of a rare biomarker. This is about 4% of patients with metastatic colon cancer. The true importance of making sure we do thorough deep sequencing in all of our patients. The study is 35% accrued. There are discussions about potentially turning back the sample size slightly, and we're waiting those further discussions. Next slide, please. SWOG 1922 is yet another rare tumor. Dr. Overman from Anderson is the PI, along with his collaborators, Dr. Peterson from Alliance, Salem from NRG, and Dr. Callian from ECOG. This trial is a second-line randomized trial of ramucirumab and paclitaxel versus FOLFIRI for patients with metastatic small bowel adenocarcinoma who progressed on first-line FOLFOX or CAPOX. The study's been open just over a year and has accrued 8 patients. Next slide, please. So here you can see the schema, second line or beyond, ramucirumab paclitaxel, standard dosage schedule versus FOLFIRI, primary endpoint of PFS. Once again, slow to accrue. This is a rare trial, and I would once again encourage everybody to strongly consider their patients for it. Next slide, please. SWOG 0820 is our prevention trial, a double-blind, placebo-controlled trial of eflornithine and sulindac to prevent recurrence of high-risk adenomas and second colon cancers in patients with 0 to 3 colon and rectal cancers. This is the PACES trial. Dr. Zell has been the PI, and he's been incredibly persistent in getting this trial closer and closer to completion over the years. Next slide, please. This was originally a 4-arm trial, but closed to just the straight randomization between eflornithine and sulindac versus placebo. The trial is accruing about 4 to 5 patients per month, and it's 75% accrued almost. It's really starting to come along. So our hope is this trial will complete over the course of the next 2 years or so. Next slide, please. We're now going to switch to the NCTN trials. We have a number of those open, and we'll run through those. Next slide, please. The Atomic trial, the SWOG PI is Dr. Liu. This is an adjuvant immunotherapy trial. Patients with MSI-high disease after resection are randomly assigned to FOLFOX or FOLFOX and atezolizumab. This trial is accruing briskly, about 14 patients per month. It's accrued 422 out of 700 patients. And we'll move on to the next study, please. NRG-GI004, otherwise known as SWOG-1610. The PI is Dr. Rocha Lima, and the SWOG PI is Dr. Overman. A randomized phase 3 trial of atezolizumab monotherapy versus FOLFOX-Bev atezolizumab in the first-line treatment of patients with deficient mismatch repair or MSI-high colon cancer. This trial is open throughout the NCORPS, 410 sites enrolled, and it's accrued 69 out of 211 patients. Next slide, please. So this was originally a 3-arm trial, but after the approval of first-line immunotherapy for metastatic colon cancer with deficient mismatch repair, the FOLFOX Avastin arm was closed, so it's now a straight 2-arm trial. It has recently reactivated. It's now open again to accrual, and I would once again encourage all of you to put your patients with mismatch repair defect on this trial, and we can get it done. Next slide, please. NRG-GI005, this is the phase 2-3 study of circulating tumor DNA as a predictive biomarker in adjuvant chemotherapy for patients with stage 2A colon cancer, the COBRA trial. Dr. Van Morris is the PI, the SWOG champion, Aaron Scott from Arizona. The trial activated 1.25 years ago. The accrual target is 1,400. It's accrued 115 patients, 3 of them from SWOG. The trial has been on temporary closure since December and is just about to reactivate. It was placed on hold because of the FDA approval of the Signatera assay that required some changes to the consent form. This trial takes patients who have resected stage 2A disease for which the physician has felt the patient is suitable for follow-up and active surveillance with no treatment. The first arm is a randomization to standard of care, which is active surveillance, and their circulating tumor DNA is collected and looked at retrospectively. Arm 2 is assay-directed therapy. Here, the circulating tumor DNA specimens are used prospectively, and if there's no detective circulating tumor DNA, the patients go on to active surveillance. If there is positive circulating tumor DNA, they are switched to adjuvant therapy with either FOLFOX or CAPOX at the investigator's discretion. So this trial is soon going to be reopening. Next slide, please. The Solaris trial, study chair is Kimi Eng from Dana-Farber. The SWOG champion is Dr. Cohn from SCCA. And this is a randomized double-blind phase 3 trial of vitamin D supplementation in treatment-naive colon cancer, metastatic colon cancer. Next slide, please. There is ample data that has shown that vitamin D is prognostic for survival. So this trial is going to explore this in a definitive way. Untreated patients are randomly assigned to FOLFOX or FOLFIRI with Avastin, investigator's choice, to either high-dose vitamin D, a loading dose of 8,000 a day for 2 weeks, and then 4,000 a day, versus 400 units a day. Primary endpoint of PFS, secondary endpoints of response and survival, and following vitamin D levels and lifestyle. 400 patients is the target, and 176 have been accrued, so it's nearly half done, 9 of those from SWOG. A recent amendment allowed the use of bevacizumab biosimilars, and this is obviously going to be important as we design all of our trials moving forward to make sure we're allowing biosimilars right out of the chute. Next slide, please. So that summarizes our active studies, both in-house SWOG studies and trials that we're supporting through the NCTN mechanism. I'll now briefly review several concepts in development. Next slide, please. Doctors Golami and Grothy are developing a platform to study immune augmenting treatment strategies for microsatellite stable colorectal liver metastasis. You'll hear more about this platform. They'll basically be neoadjuvant therapy, potentially TKI and immunotherapy, and then liver resection. And this is still in ongoing development. The second concept is quite far along in its development. In fact, it's going to be presented at the GI Steering Committee this coming Monday. Hats off to Dr. Morris for doing an incredible job getting this study ready. This study will follow up our prior BRAF experience in which SWOG 1406 was accomplished, and Dr. Kopetz was the PI for that trial. This is a randomized phase 2 trial of encorafenib and cetuximab with or without nivolumab in patients with microsatellite stable BRAF V600E mutated metastatic colon cancer. So we look forward to what will hopefully be a successful review by the GI Steering Committee next week. The third study in development is in collaboration with our surgical colleagues, a debulking cytoreductive study with HIPEC for high-grade appendiceal cancers with Drs. Patel and Dr. Dineen, and that concept is very far along in its development. Next up, Dr. Krishnamurthy and Senthil have presented a randomized phase 2 trial of preoperative chemotherapy with or without nivolumab and ipilimumab for colon cancer. This past week, this was quite successfully presented at the colon task force, and this capsule is now in development, and we hope to see this study mature and move along the path towards approval. Finally, Dr. Liu, in partnership with Dr. Desari at NRG, have created the Circulate-US trial. This is a colon adjuvant chemotherapy based on evaluation of circulating tumor DNA, not too dissimilar from the COBRA trial I mentioned earlier. Next slide, please. This is the last slide. In contrast to the COBRA trial, this study is for patients with stage 3 disease, in whom if there's no circulating tumor DNA, they'll be assigned surveillance, randomized to surveillance or chemotherapy. In those patients where there is circulating tumor DNA detected, they'll either get standard of care capecitabine and oxaliplatin or be randomized to a more aggressive regimen of FOLFOXIRI. This protocol has been through GI Steering Committee and is in development, and we look forward to an activation in the coming months. And I want to thank everybody for their attention.
Thank you, Phil. This was great, and thank you, Wells. Also, both of you did a great presentation. I just want to ask one question while we're going to the next slide. No new drugs in colon cancer, apart from immunotherapy?
Them is fighting words, Philip. Yeah, I mean, there's a number of things under development, not quite ready to move forward, but I do think there are some signals that we'll hopefully be able to follow up on.
Okay, thank you. Again, I don't see any other questions, so thank you both. And we go next to rectal and anal, and we have 10 minutes for it. Please go ahead.
Hi, I'm Lisa Kachnik, and on behalf of Dr. Hagen, Konecki, and myself, we're going to quickly go through our subcommittee. Next slide. So next slide, just to give you the recent landscape in rectal cancer. Currently, there are no open trials, so we are all working together in the adult cooperative groups to come up with some, and you'll see some developing concepts towards the end. So right now, total neoadjuvant therapy is quite hot in terms of trial development. Despite local regional relapse rates of 5 to 6%, long-term survival's not perfect. And we all know that for every GI cancer, trying to give adjuvant therapy after surgery is very difficult. So total neoadjuvant therapy has been really the emerging platform, so far studied in very advanced distal bulky, a large nodal burden disease, and thinking that this might be a strategy for earlier treatment of micrometastatic disease. Next slide. So in my cartoon representation, our traditional approach which has been based on the German rectal study, chemoradiation long course in the States, TME, and then adjuvant chemo. But you'll see that have been presented at ASCO in abstract form over the last year for giving TNT. It could be either chemo, long course chemoradiation, or more recently, short course alone, or doing the chemoradiation or short course up front and then chemo and surgery. Next slide. So the NRG TNT original, I guess the NRG probably named it TNT study, did have 2 arms that was reported on at ASCO. This was an approach giving FOLFOX up front, long course chemoradiation with control of capecitabine with experimental arms looking at a PARP inhibitor and pembro. And they had a primary endpoint of neoadjuvant rectal score, which was trying to take into account all of downstaging. So not the black and white PCR, although that was an important secondary endpoint. Next slide. So neither of their experimental star score, it was adjuvant regression, not rectal, that they had thought would be as their primary endpoint. Interestingly, had pretty good PCR. Was 32 and the Claparib, the PARP inhibitor, was 34. But needless to say, it didn't meet its primary endpoint, and this trial is now closed. Next slide. And then also at last year, ASCO for 2020, we had further evidence to support TNT. On the left is the PRODIGE 23 trial, and on the right, PRODIGE was actually looking at FOLFOXIRI and then chemoradiation versus standard chemoradiation before and further adjuvant chemo. And if below, the disease-free survival at 3 years, which was their primary endpoint, was significantly FOLFOXIRI arm. Keto was one of the first trials here to look at TNT, but with short course radiation. They gave short course radiation, 5 gray times 5 fractions in a week. Choice of type is capecitabine-based long course radiation and TME. Their primary endpoint was disease-related treatment failure. That was for the short course arm. Next slide. So the other thing that we're working on in all of the adult groups, and you'll hear about today, is organ preservation or watch and wait. Now, organ is really important for patients with rectal cancer for obvious reasons, but we haven't yet been successful in launching a trial, probably because the key to it is rigorous follow-up with imaging and pelvic MRI. But I think the prospect trial in the States that we're still waiting for the results, which will be in about 1.5 to 2 years, has really helped us get better at pelvic MRI. Next slide. So again, ASCO 2020 was a big year for localized rectal cancer. The OPRA trial was presented at ASCO, and this was a trial for the same stage as the previous slides, which I got to mention, T3, T4s, stage 3. And they were randomized to induction chemotherapy, chemoradiation long course, and TME or non-operative management if it met the eligibility for this. And chemoradiation, you're seeing a theme that's going to be rising, and then the chemotherapy. And they actually found that more TME-free results when before the chemotherapy. So you can kind of see that theme that giving maybe the radiation a longer time to kind of have a downstaging effect seems to work. Next slide. So keeping that in mind, questions for all of us in this rectal localized cancer lane is designing the appropriate watch and wait trial, the optimal chemotherapy for TNT, what organ sparing strategy for early rectal cancer works, and sort of what to use in terms of chemo and radiation. And then, is trimodality therapy really needed for all stage 2 and 3 rectal cancers? Are there biomarkers we can use to help guide us in this? Next slide. So just to show you our open trials, and then you'll hear about those sort of thoughts in the developing trials. We have accruing very well 20 AIMS trial. I'll go over that in a second. And then we have 3 open trials that are on our virtual meeting today. Next slide. So next slide. So the PI for the AIMS trial is Dr. Virginia Sun, who is on, and this is a randomized trial looking at an interventional arm of coaching for managing symptoms related to bowel dysfunction in rectal cancer survivors compared to a healthy living education control. And take rectal cancer survivors that are between 6 and 24 months after treatment. They can have an ostomy or anastomosis. They have to have a low anterior resection symptom bowel score of a standardized instrument of 21 to 42. And then they get randomized this very intense intervention arm, intense you with symptom intervention after reviewing your symptom, versus more healthy living type control arm. It's accruing very well. It's over halfway accrued ahead of schedule, and I would urge everyone to put patients on it. Next slide. So now we have 3 open intergroup anal trials. Next slide. The first is the decrease trial. That's actually looking at de-intensifying radiation for early stage anal cancer. So if you have a T1 or a small T2 N0 cancer, you are eligible. You get either randomization dose, which is 54 gray. You get de-intensified radiation, 36 gray 1, and for T2, 41.4 gray. Chemo is pretty standard. This is accruing well. It recently opened, but it's accrued 41 at 252, and we have it open here. Next slide. So now we have the EA 2165 trial. This is looking at adjuvant Nivo for locally advanced anal cancer versus observation. It's almost close at 320 out of 384, and SWOG's been approved well to it, so thank you. Next slide. And then lastly, we have EA 2176. It's also a randomized phase 3, but this one's looking at immunocheckpoint inhibition with chemotherapy in naive metastatic anal patients. They get randomized to co and taxes, carbo and Taxol and Nivo. It's a 2-to-1. Our indicators are all on the lead, the co, and SWOG on our meeting today. So congratulations and opening. Just started to enroll. We're at 6 out of 205. So please open this at your institutions. Next slide. So now I'd like to introduce my co-chair to review our developing trials.
Okay, I think I have 0 minutes. So we have one slide that is a summary slide, and I'll focus on that. Thanks for the great summary, Lisa. I appreciate that. So we'll just zip through this and then respectfully give the time to our NET colleagues. The first on the agenda is the locally advanced anal study trial with David Horwitz and Mei Cho. This is actually not formally on in our queue. This is going to be developed through a investigator-initiated pathway. That is the aim. However, we did want to keep it listed. And as you can see, this is a treatment escalation with dual IO therapy for high-risk anal cancer with dual IO therapy given with 2 different chemo backbones. So we've seen this a few times at SWOG. We made the decision that it is a small study and we will kind of put this on a different track for now, but we will keep a close eye on it, and we're continuing to support David and May on it. The second concept is the Neo-RT, which we had excellent discussion on yesterday, giving updates of the precursor trial, the Neo study, and that is moving along, and we have a plan to review that also at CCTG, discuss that hopefully within the SWOG system for triage, and then identify our US and Canadian teams. And I look forward to presenting that data at the ASCO 2021. 3 more quick updates. There was a proposal put forward in the TNT study that, as you hear, Lisa said, that is closed, that is being withdrawn. However, the concept of comparing neoadjuvant FOLFOXIRI to neoadjuvant FOLFOX in the TNT setting is very much alive and has migrated over to the new Janus trial concept, which is a mega multi-NCTN group study of NRG and Alliance and SWOG. However, it is led by the Alliance group with Dr. Smith, who presented yesterday, and we are going to see that at the RA task force presented in May, unless there's any objections. Another ARM proposal was put forward for SWOG by Dr. Kim, did not go forward along with the rest of the TNT study. And then finally, we had some discussions at length yesterday by Dr. Stacy Cohen presenting a randomized phase 2 concept of dose treatment de-escalation based on ctDNA clearance. I think, what I would say to that in the last, 30 seconds is, there's scientifically, there's lots of strong rationale for that. The challenge is to really develop the statistics around that and see whether it can be done in a feasible number of patients. Stacy does really want to take a run at the RA task force presentation, and we're aiming either for May or for July, and we're going to be working on that, the concept within the rectal anal subcommittee before then, and appreciate everyone's support in that process.
Okay. Thank you very much, Hagen, and thank you very much, Lisa. These were excellent, outstanding presentations telling us what the landscape is and where things are moving. This is extremely helpful. Extremely helpful. Thank you very much. Okay, so now we go to our final presentation on neuroendocrine tumors. Can we go to the next slide, please?
Yeah, we're going to have to zip through these.
Next slide.
Yeah, keep on going. Yeah, keep on going
Next slide.
because we're not presenting this.
Yeah. Next slide. To neuroendocrine. Next slide, next slide, next slide. Okay, here you go. Okay, so John and Arvind.
Yeah, I'll be presenting on behalf of John and myself. This is Arvind Dasari. Next slide, please.
So we have 5 minutes. 5 minutes.
This is the current treatment landscape. No major changes since the last meeting. Just want to point out that surufatinib is a multi-VEGF TKI currently pending approval by the FDA and is under review. Next slide, please. And this is based on 2 large phase 3 trials done in China, as well as a smaller trial done here in the US. Next slide, please. Maybe in the interest of time, I'll move on and focus on kind of some of the ongoing NCTN trials. Next slide, please. Next slide. An update on the a trial being run by ECOG EA2142. It's a randomized phase 2 study of platinum and etoposide versus temozolomide and capecitabine in patients with advanced G3 gastroenteropancreatic neuroendocrine malignancies. This has been open for several years, and the study was closed after interim futility analysis after about 65 patients were enrolled. The SWOG champion is Dr. Soares. Next slide, please. The CABINET trial, which is a registration trial of cabozantinib in advanced neuroendocrine tumors, enrolling patients into 2 cohorts, is currently ongoing. There are some amendments with regards to eligibility and also allowing crossover, after which the accrual is picked up. The SWOG champion is Dr. Strasberg. Next slide, please. This is a trial of Lutathera versus everolimus in well-differentiated neuroendocrine tumors. The SWOG champion is Dr. Hendifar, being led by Drs. Hope and Dr. Pada. It's awaiting final approval before opening. Next slide, please. Moving on to the SWOG concepts and development. Next slide, please. This is a phase 2/3 study of first-line platinum and etoposide with or without atezolizumab in patients with poorly differentiated extrapulmonary small cell neuroendocrine carcinomas. Patients will be randomized to platinum etoposide versus a platinum etoposide plus atezolizumab followed by observation, or the same treatment followed by maintenance atezolizumab. The primary endpoint is overall survival. It's being led by Drs. Zend and Chiorian. The protocol is under development. Next slide, please. You've already heard about this trial earlier today, looking at the role of adjuvant capecitabine and temozolomide in patients with resected pancreatic neuroendocrine tumors, being led by Drs. Soares, Ahmad, and Washington. The protocol was submitted to CTEP. Next slide, please. And finally, there is a CTPM done for neuroendocrine tumors, and several concepts were discussed. One of the concepts that may potentially move forward is looking at retreatment of patients with neuroendocrine tumors with PRRT and comparing that to everolimus. Still waiting on the final word and looking forward to developing this through SWOG. The PI is going to be Dr. Aman Chauhan. I think those are all the updates from the neuroendocrine group.
Well, thank you very much. That was on time, really on time. So any questions? Anyone wants to make any comments on neuroendocrine or anything that was presented today? This is the time to tell us if you have any anything you want to add. Certainly, you will have the opportunity to send us any emails, texts regarding comments, questions, concerns. We'll be more than happy to have them. If not, then I would like to thank everyone. I would like to thank all the speakers today, subcommittee chairs. I'd like to thank our SWOG support that we have. And also, I'm really very thankful to on behalf of myself and also Kathy, so all the providers and people working on clinical trials in the community. This is a large SWOG community, and most importantly, the patients and their families. Kathy, do you want to add anything?
No, I think everyone did an amazing job today. I know several of us were stuck in clinic and dealing with clinic issues despite everything. So I think it went overall pretty well, and we're only 1 minute over.
And then we will be looking forward to see them all in 5 months in Chicago. Is that correct, Kathy? In person.
I hope so, but who knows? I don't want to jinx us.
Okay, well, thank you very much again, and go back to your clinics or whatever you're doing. Thank you. Goodbye.
Thank you.